Good afternoon, everyone, and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenauer, and today I'm joined by Lauren Chapnick, Outpatient Adult Intestinal Transplant Surgery Nurse Practitioner, and Ashley Satter, Adult Small Bowel Transplant Coordinator with MedStar Georgetown Transplant Institute. And today we're discussing small bowel transplant. We'll be talking about the vital role your small bowel plays, how to know if something's wrong, treatment strategies, and more. So if you'd like to learn more, then stick around, give us a like to let us know you're watching, and share this broadcast with your friends. And if you have any questions for our experts, you can ask them in the comments below. Lauren and Ashley, welcome. Thank you for being here today. We really appreciate you guys taking the time out of your day to speak with us. Before we begin, could you guys tell us a little bit about yourselves and the work you do at MedStar? Lauren, if you want to start.
Sure. So hi, everyone again. I'm Lauren Chapnick. I'm the nurse practitioner who sees all of the post-intestinal transplant patients. And now I work on the outpatient team, but for years before this, I worked on the inpatient team. So basically, my role is to see everybody after transplant, manage, their care, their medications, any procedures they need. And then what's nice is I get to follow patients basically for forever. They come back every year for their annual visits. So it's also really wonderful to see patients doing really well years out, and the patients who are new, I get to manage, some really complex cases, which is really exciting, and it's wonderful to see these patients do really well. So it's been wonderful.
Great, thank you. Ashley?
Hi, so I'm Ashley. I'm the pre-transplant coordinator as well as the dietitian. So I help patients on the pre-transplant side before they transition over to Lauren. I help coordinate their transplant evaluations. We do a whole bunch of testing on them to make sure that they can actually get a transplant. And then I also manage their nutrition before their transplant. A lot of the times that's parenteral nutrition. And then after their transplant, I help them transition to a more normal diet now that they don't have, intestinal failure. And we'll talk about all these terms that I just said in the presentation. Jumped the gun a little, but that's me.
Great, thank you. Well, thank you both again for being here today. Let's get into the questions. So first of all, start off, pretty basic. What is the small bowel and what does it do?
Yeah, so the small bowel is actually a really huge organ. The small intestines is about 20 feet. Depends on how tall you are. Sometimes it's shorter, sometimes it's longer, depending on your height and size. And the large intestines is 5 feet long. So it's about 25 feet of organ. And the role of the small bowel is to absorb macro and micronutrients. Macronutrients are our carbohydrates, protein, and fats, and micronutrients are our vitamins and minerals. So, food goes through the esophagus and the stomach and then trickles through the small bowel all the way out through the colon, and it absorbs all of those, vitamins, minerals, and energy that you need to survive.
Great, thank you for explaining that. So then what is intestinal failure?
So intestinal failure is basically when your body is unable to do all the things that Ashley just said. So if your body cannot absorb nutrients or can't get enough of them, that is what intestinal failure means. And typically it comes from one of two issues. Number one, that your gut has what we call a functional problem, meaning that the function of it is not working. So for some reason, the anatomy or the outside looking, if you want to say the outside of your organ works fine and looks normal. But when you're eating, something isn't working, it's not going through well, or it's not absorbing well. So you're just not getting all those calories that you're supposed to get. And then the other problem is a problem if you can't get nutrients because of the length of your bowel. And that would be for people who have certain disorders or have gone through some sort of trauma where they have a shortened gut. Then that's a physiologic problem because your gut's just too short to be able to absorb those nutrients. So those are the two reasons that you could wind up with intestinal failure.
Okay, and then what are some of those symptoms that patients might experience that they have intestinal failure?
Yeah, I think the biggest things to remember is that if you are having GI symptoms, which are easy for people to tell, right? You have really bad nausea, vomiting, severe diarrhea, severe constipation. You've been told that things don't move through your GI tract correctly. Or if you have inflammatory bowel disease, such as Crohn's disease, ulcerative colitis, things like that, then already you kind of know that there's an issue there. If you are seen by, first of all these patients should be seen by a general gastrointestinal doctor who should manage them. And then basically, if they're starting to have worsening symptoms that aren't controlled, if they're starting to have multiple surgeries to the point where the surgeons are telling them they're not really sure what's going on, or if you ever have like severe, like acute onset, oh my God, 100, like 10 out of 10 pain, very severe. And that is definitely something that sometimes could be an emergency. So that is definitely a reason to go like directly to the ER. So that is definitely something we would tell people to look out for as well.
Great, thank you. Yeah, that was gonna be my next question, was asking what are the steps that you take when you're experiencing this? But as you said, it kind of depends on how severe the symptoms are. And so then, can you explain intestinal rehabilitation?
Yeah, so intestinal rehabilitation, the goal is basically to optimize the bowel that you have. So most of the patients that we see undergoing intestinal rehabilitation have short bowel syndrome. So they've had resections of portions of their bowel, and therefore their nutrition status and their hydration is compromised. So we do multiple things with these patients who have compromised intestinal absorption. We may put them on different nutritional therapies. That may involve feeding them through tubes. It may involve giving them certain types of foods, putting them on specific diets to help them better absorb the food that they're taking in. Or it may involve something called parenteral nutrition, which is essentially IV nutrition. So we use these different nutritional tools to make sure that the patients are able to maintain their weight and to prevent any micronutrient deficiencies. We also use a lot of medicine and surgery to help these patients to optimize the bowel that they have as well. A lot of different medications can be used to help slow down transit for patients who are having a lot of diarrhea, or if they're having the opposite effect, we use medications to increase intestinal motility. There's also some non-transplant surgeries that our team does to help improve the function of the bowel they have remaining too. Intestinal rehabilitation is kind of the first step to make sure that we optimize any remaining bowel that is left before we move on to any more extreme measures to remedy the patient.
Great, thank you for explaining that. So now going into the transplant side, can you talk about intestinal transplant and what that entails?
Sure. I think first we wanted to talk a little bit about what are the indications for that transplant.
Yeah.
So as Ashley said, we try to optimize people to see what kind of function they can get out of the bowel that they already have remaining. Mm-hmm. So basically, once that occurs, if someone goes through an evaluation and we decide yes, they should be transplanted, part of that evaluation is what is their underlying diagnosis. So do they have something like Crohn's disease, where we talked about how they might have had multiple resections of their bowel and they have like very short amount of bowel. So things like very short amount of bowel where you can't absorb the nutrients, things like a traumatic injury such as a car accident, or for veterans like an IED explosion. People, one of the things we talked about that could be concerning is acute onset of very intense pain. Sometimes that's one of our first indicators that someone has a blood clot that is clotting off and blocking any blood flow to their bowel, and their bowel could actually die from that. And then the other thing that Ashley was talking about is how some of these people need sometimes parenteral nutrition, which is IV nutrition, because their bowel is so short. So people who wind up having lots of bloodstream infections from the central line that they have, that is also a reason that somebody might need to progress to a transplant, as opposed to just being able to be managed the way that Ashley was talking about with the rehab. Mm-hmm. And the transplant itself is, as Ashley had alluded to, there's a very extensive evaluation process, and that's usually done over several visits. And once somebody is listed for transplant, one of the things we talk about is Ashley does all of our consents for transplant. So she goes over all kinds of information about what is the transplant and what are the statistics around it and all of that. And then the surgery itself is typically done by Dr. Matsumoto, who is our head bowel transplant surgeon director, and at least one or two other of our liver and bowel surgeons here. And then basically they go in, and it depends on the exact anatomy of the bowel, but they basically take out the person's bowel that is the recipient, and a donor bowel is brought into the operating room, and that is surgically placed. And then the patient is usually admitted for several weeks after transplant. And as Ashley was saying too, it's a very intense process, and the dietary part is one of the biggest parts. So like Ashley said, a lot of these people are on IV nutrition, and then she really helps too with transitioning from that to feeding through tubes, and then ultimately eating without those assistances. And then all of our patients also get ostomies, and we do scopes through the ostomies to take biopsies to rule out any rejection. So just like any other organ type, these patients can also get rejection that has to be monitored and treated. So that is kind of the biggest things that happen in the first several weeks. And then they get very close follow-up care with me and Ashley, Dr. Matsumoto, Dr. Subramanian after the transplant for several months, until we see if their ostomy can actually be reversed or basically put back inside. And then hopefully, if all that goes well, then we kind of spread out all the appointments, and then we get to see them annually. And that's, like I said before, something incredible, especially, for Ashley and I, when we get to see them, sick before transplant, and then you see them after, living a whole new life. It's actually really remarkable.
Yeah, I'm sure that sounds like it'd be super fulfilling and rewarding to be able to see that whole journey and be with them throughout every single step. So thank you for explaining that. I'm going to pause real quick and just tell our viewers, thank you for joining us. And if you're just now tuning in, we're here speaking with outpatient adult intestinal transplant surgery nurse practitioner, Lauren Chapnick, and adult small bowel transplant coordinator, Ashley Statter. Both are with MedStar Georgetown Transplant Institute, and we're discussing small bowel transplant. We have more to talk about, so stick around, give us a like to let us know you're watching, and share this broadcast with your friends. And of course, if you have any questions for our experts, please leave them in the comments below. So my next question was, what are the indications of a small bowel transplant is needed? But we just talked about that. So I'm kind of wondering, you talked about, it could be people who have experienced trauma. Is there also a certain age range of people that typically are, more susceptible to this, or anything like that?
Yeah, that's a good question. It's a pretty wide age range, I would say. Kind of, it can impact pediatric patients to adult patients. We've done, patients as young as I think a few months old, and our oldest was I think 65 or 66. So it's quite a big range. There's so many different reasons why someone would develop intestinal failure. Some, patients are born with some sort of congenital abnormality, which may lead to short gut syndrome. We have patients who have experienced, trauma, which can happen at any age, gunshot wounds, motor vehicle accidents. We also have patients who've had, Crohn's disease and colitis. These are diseases that typically surface around the teenage, early 20 years, but sometimes they come later in life. And sometimes, we've seen them start as little kids too. Cancers too, we've seen a lot of, rectal cancer, colon cancer that has become, severe. So it's a pretty wide age range, which definitely makes, the job exciting. You see so many different types of patients. It's a very heterogeneous population, a lot of different diagnoses, a lot of different reasons why our patients are here to see us.
And so then with that, Ashley, you said you work with the, their diet and everything. Is that individual per patient, or is it kind of the same sort of general idea for each patient?
Yeah, it's super individualized. We have some guidelines. There's certain things that we tell all patients to avoid in the early stages of transplant. It's a pretty strict diet right after transplant. We limit a lot of things. But then over time, every patient kind of goes their own path, and it's very different. We have to take into consideration, first of all, what the patients like. If they don't like the food they're eating, they shouldn't eat it. So patients all the time ask me, what's the perfect diet I can eat? And I said, that's a different answer for every person. Right. We also have to take into account, culture too. Different people have different cultural foods they enjoy, social needs. So everyone's diet plan is super individualized. It's interesting as well. We have some patients who really have not eaten or, eaten to completely support themselves for most of their lives. So when they do get a transplant, it's a huge shift to then all of a sudden have to support yourself through your nutrition by mouth. You no longer have a tube or an IV to support you. So it's really a lot of behavioral work to get these patients to be able to feel confident that they can support themselves and maintain their weight with just an oral diet. On the other hand, we have some patients who, pretty seamlessly just start eating. I've had patients come in and they're like, yep, I'm eating burgers, I'm fine. And I'm like, well, my job is done here. That's So it's again, very heterogeneous population. Every patient has a different story with different needs. And yeah, it makes it a super rewarding, challenging, but rewarding job.
Yeah, I was gonna say, I'm sure probably pretty challenging. I know, especially with me, I'm a very picky eater, so I don't know if I'd be a super easy patient for you. So kind of continuing talking about post-transplant, what does that typically look like for a patient, and how do both of you kind of work with the patient both post-transplant? Lauren, if you want to start.
Yeah, absolutely. So post-transplant, like we kind of talked about a little bit before, immediately after transplant, everybody's in the hospital. They start out in the intensive care unit, and they're in the intensive care unit for about a week or so. And then they're usually hospitalized for the next several weeks afterwards while everything is sort of, kind of optimized. Their, intestine is working, they're on, either tube feeds or oral nutrition or both. We've made sure that their graft looks good. They don't have any rejection, anything like that, that they're, strong, and they're going to go home and continue to work with physical therapy. And then when they first come out, they typically see myself twice a week for the first couple weeks while, everything is new and it's a lot of medications to get used to. And, they have to empty their ostomy bag and measure, what comes out of there, and measure their urine, and measure what they're drinking every day, and flushing their tubes. And so it's a lot. I tell my patients it's a full-time job, when you're first out. Yeah. So, once they get the hang of it, it gets easier. But the first couple weeks, are a lot for them and their caregiver. Ashley sees the patients with me usually at least once a week, sometimes twice at the beginning as well, just depending on where they are in their nutrition journey. And then, after the first couple of weeks, if things are going well, then we kind of cut back to once a week visits, and then we'll kind of go to every 2 weeks. And then typically about that time, it lines up fairly closely with the amount of scopes that they need per week. Just depends again on, how well they're recovering. And then, once they get their ostomy reversal, or again, their takedown where that goes back inside. So we do this because everybody gets a loop ileostomy, meaning that their stoma is kind of put almost like if you took like a hose and went like this, then there's like a little hole, so it all comes out of here. And then that way, when it's time to take it down, you just kind of put it back together, if you will, and put it inside. And so once people get to that point, that's a couple months out. So by then they're usually off, any sort of nutrition, either IV form, usually also the tube form. They're usually eating well by themselves, able to kind of get around, they've like healed very well from their surgery. And, typically that's somewhere around 4 to 6 months after surgery that we do this. So you could imagine Ashley and I are seeing these patients for months after transplant pretty routinely. Yeah. And then somewhere after that takedown, for about another month or so, we watch them pretty closely. And then we kind of say, patients can, kind of slow down and just do labs every month. And then we kind of see them for another big visit at their annual visit. So for patients who come here from far away, which is one of the things that, our transplant center is really known for, is that people come from all over, not only, our nation, but other nations. So, at that point, we usually say that's when patients can kind of go back home. So if we have a patient, who came here for transplant from Texas, they've lived here for those, 4, 5, 6, 7 months where they're seeing us so consistently. And then once things are healed, we'll say like, okay, you can go home. You're going to get monthly labs. You're still going to talk to me all the time, talk to Ashley, use the portal, send us messages, call us. So it's a very intense process, and, patients and caregivers are aware of that from the beginning. It's one of the things Ashley covers in consents and during the evaluation process. So that's not a shock. They know they're going to be here for a while.
Yeah.
But yeah, so it's also great because you get to know the patient and their families really well, and they get to know us really well.
Yeah.
What do you
Yeah.
think,
And
Ashley? Anything you would want to add to that, or?
Yeah, I'd say it's a huge part of the pre-transplant process is talking about, how are you going to live here after transplant? I mean, DC rent is not,
not cheap.
no, don't pay it. It's not great. But it's hard. It's a huge hardship for patients to have to go through to live here. So much of the pre-transplant evaluation is number one, getting them through all the tests, getting them through the cardiac testing, the scopes, the CT scans. But it's also talking with the patients, with their families, very candidly, and saying, who's going to be up here and take care of you? Who's going to be that designated person who will take you to clinic, and where are you going to live, and how are we going to do that? A lot of our patients will work very closely with our social worker, and she can, kind of help guide them. We can't, always like find them housing, but help guide them to find places, and then also to fundraise. That's a huge thing that a lot of our patients do. Bowel transplant is rare. It's a huge undertaking. We really encourage our patients to share their story and to fundraise, because we've had patients who this is possible just due to proper fundraising. We try to get them started on that early as well. And then also to have, a backup, caregiver support team as well. You need a primary and a backup, but kind of the more people that will rally together and help you, the better. So there's definitely a lot of, psychosocial components that make a patient a successful transplant candidate. It truly takes a village too.
Yeah, I was gonna say it sounds like it, and it's, I'm sure, great for them to, have people like you guys who help them with the entire process, not just, the medical aspect of it, but like you said, finding the housing if they're coming from out of town and knowing the area, stuff like that, because that's added stress on top of the stress they're already going through needing this surgery done. So
Yeah.
it's great that they have you guys to help them out.
Mhm.
So we actually do have a question from one of our viewers. Janelle asks, are all donor intestines universally compatible with all recipients? Are there any parameters for determining who gets which donor intestines?
I'm gonna let Ashley take this because she deals with us all the time on the free side. Yeah.
I do. So this is a really good question. There are a few things that we consider when we are matching our donors to recipients. The first is the blood type. So you have to have a blood type match. So if you have A blood type, you got to find an A. The second thing that we look at is the size. Like I said before, the intestines is a huge organ. Liver and kidneys are pretty small in comparison, so it doesn't have to be as stringently size matched. But bowel's huge, so we have to put in pretty strict parameters for the sizing of the intestines. For a lot of our adults, they need pediatric donors. We don't like to think about that, but they need those smaller organs to fit into their abdominal cavities. And then the third thing we look at is something called the panel of reactive antibodies. This is a lab that we get that basically shows a panel of the antigens that a person has, and that is used for immunologic matching. A lot of science behind that I'm sure will bore everybody, but that's a really important lab that we get to let us know, what kind of donor pool are we looking at and what donors are available that would match with that recipient from an immune standpoint.
Okay, great. Thank you for explaining that, and thank you for your question. So before we wrap up, I just wanted to ask you guys, both of you, what message would you like our viewers to take away with after watching this broadcast? Or if there's anything that you guys want to touch on that we might have missed, we can do that. And then we'll get back to the wrap up question. Lauren, do you want to start?
Sure. So I would say, I think the biggest takeaway from this is to say, if you are somebody who is interested in intestinal transplant, if you are, let's say, like a nurse or an NP or PA, it's definitely something that's really rare and really interesting. It would be definitely a really cool career. And it gives you so much insight medically and surgically, which is kind of neat. And as a patient, I would say, if you are struggling with GI symptoms, as we said before, the first thing to do is seek out a gastroenterologist. Like Ashley said, this is a very rare surgery. So this is not like, oh, I'm having occasional diarrhea, I should get a bowel transplant. That's not what this is for. But, if you are someone who has been seeing a GI and, they're really struggling, a referral to a small bowel transplant center might be worth looking into. They can always tell you if you're eligible or, put you through an evaluation. And I think the other thing is, if you're somebody who, has sort of like acute onset of pain or things like that, a lot of people will say, oh, I'll just tough it out, or, I don't want to sit in an ER and wait 12 hours to be seen. But just to kind of know that, there are cases where things happen acutely and you weren't planning on them. And some of these people who have these blood clots, they've never been sick before. They never had a history of blood clots that they've known about before. So, I think that's also something to kind of just put away in the back of your head, that, your body tries to tell you something. So if you're in severe pain, it's typically means something is wrong and you should be evaluated by an emergency department. Other than that, I think, if any of our patients are watching, anybody who's listed or has undergone transplant, just, to say we love what we do and we're so grateful. And, just that this is an incredible opportunity that we all have, and we love working with our patients. And yeah, I think that's basically it. What about you, Ashley?
Yeah, so I was going to say that any, providers watching out there, nurses, really anybody in healthcare, if you have a patient that you suspect may need intestinal rehabilitation or intestinal transplant, reach out. I think one of the hardest things that I have to deal with in our job is when patients are referred too late, when they're too sick, when they're too malnourished, or they're too old, and then we can't do anything. There's many patients that I've seen where I look back and I'm like, oh, what if they were referred 5 years ago? The worst thing that happens if you reach out is that we say they're not a candidate. But I think the more that we put this information out there and educate providers and patients, the better advocates they can become, and then they can really get the care that they need. I think that's really key with any of these rare surgeries and these rare diagnoses, to give patients and providers the knowledge to know who to contact and when.
Right. Exactly. Well, thank you. I think that was both great ways to wrap up our broadcast. Thank you so much to you two for being here today again, and for giving us a lot of valuable information on this. We really appreciate it. And thank you to our viewers for tuning in. For more information on MedStar Georgetown Transplant Institute, please call 202-444-1058. We'll also be posting that phone number in the comments. Thanks again, everyone, for joining, and we'll see you next time.
Thank you.
Thank you.